Greetings, everyone. This is Dr. Weaver. I wanted to go ahead and start recording the voiceover. The remainder, I believe, is chapter 48. That in med surge or adult health, and this discussion will involve dementia, Parkinson's, and I believe Huntington's disease. So let me go ahead and start sharing. Actually, I better. So I'm recording. All right, so let me go ahead and start sharing. Let's see, window here and there. All right. All right, so I think I'm sharing. Try to get through with this one um, as soon as possible so it doesn't drag out too long. All right, we're going to talk about dementia first. This is where the voiceover will start. With this disorder, it is a brain disorder affecting the central nervous system. There's significant impairment of intellectual functioning with these patients. Um, there's also impaired normal activities with them. Relationships are going to be altered in a negative way in most cases. Um, there's also impaired problem solving and emotional control. Again, we're talking about the effects on the central nervous system. Their personality and behavioral concerns that plague these patients. Now, when we talk about the term neurodegenerative, it is a term that can apply to any nervous system disorder that causes degeneration or wasting of the neurons in the nervous system. You know, the neurons are the nerve cells in the central nervous system as well as the peripheral nervous system. The disorders discussed in this section are some of the most common types of neurodegenerative disorders. Neurocognitive is another term to describe acquired neurologic disorders that causes cognitive decline. Um, Now, management of chronic conditions does not focus on the short-term stay in the hospital because of an exacerbation of the disease process, but rather the focus is really on long-term goals of helping the patient and the family to cope with this disease process, and also to maintain the patient's independence for as long as possible, because there will come a time when these patients will not be able to um, be independent and basically um, do things for themselves, their activities of daily living, and all the other business, responsibilities that people carry out, that we carry out daily, like paying bills and running a household and those kinds of things. Now, nursing care involves providing information on the management of the illness. We have to also anticipate, so we're looking at prevention and treatments of complications that might occur. And also, we want to refer these patients and the families to support groups that can help them navigate through the complexities of this issue. And also, case managers are very good at navigating and supporting these patients and families as well. Now, as these patients do decline, there will come a time when family members will no longer be able to care for them, especially in their homes. And of course, these patients will have to be admitted into a long-term care facility. Even if the family members are not working and they are at home most of the time, it still might be very difficult to manage these patients. And so they're going to need some help. Now, dementia is not a disease in and of itself, but rather it is a symptom of other neurocognitive. Remember, cognitive meaning thoughts, right? How we think. Anyway, so it's rather symptoms of other neurocognitive disorders. Now, according to the National Institute of Neurological Disorders and Strokes, patients who have dementia have significantly impaired intellectual functioning that interferes with normal personality, or rather, I'm sorry, with normal activities, as well as relationships. They also lose the ability to solve problems. Um, they uh, they lose the ability to maintain emotional control. They may also experience personality changes as well as behavioral issues, such as agitation. They may be agitated, they're delusional, and also they experience hallucinations as well. Now, while the memory loss is a common symptom of this condition, dementia, memory loss by itself does not mean that a person has dementia. So you have to think about some of the other causes that might appear that the patient has dementia. It could be a brain trauma. Maybe the individual fell at home when no one else was around, and of course they may have a hematoma that they're bleeding in the skull, the brain tissue. They develop, excuse me, a hematoma, and it's affecting their memory. So it can be other things that has to be ruled out. It can be certain disorders like hyperthyroidism. Just various conditions can also impair someone's memory. So, in other words, we have to make sure we rule out, or the physicians, they need to make sure they rule out other contributing factors. Now, some patients have mild mental status change that do not interfere significantly with their day-to-day functioning or activities. This is sometimes referred to as mild cognitive impairment, or MCI. However, patients with MCI are more likely to develop Alzheimer's disease than those without this cognitive impairment, a mild cognitive impairment. Now, there are many causes or etiologies for dementia. Some of those are Parkinson's, Huntington, as well as Alzheimer's disease, which, of course, we will be discussing here shortly. All right. Now, multiple mini strokes or multiple infarct dementia or vascular dementia are another common cause. So, in other words, some people, they've had so much damage from having many strokes, um, or the fact that they just have had multiple infarcts. Cerebral vascular accidents results in infarction of the tissue of the brain, and then they've just had multiple issues with that. They can also have the vascular type. Let's say if someone smoked all their lives, and smoking in and of itself has an effect on the cholesterol in the blood and the plaque buildup in these various arteries and what have you, diet and what have you. All of these things can contribute to the vascular type of dementia. So um, just things to consider. Now, also chronic alcoholism, neurologic infections, head injuries, and medications as well also can cause damage to, or cause changes rather, in mental status, leading to dementia. So, again, one has to keep an open mind as you work through diagnosing these patients. Now, although aging is associated with more frequent dementia diagnosis, dementia is not a normal part of aging, but in general, thinking is affected by changes in the brain itself that result from a reduction in blood flow, or from structural changes related to these disease states. I think I'm going to put you all on mute when I do that again, so apologies. All right. Uh, let's see. Now, some of the people who have a masters. They these people are lower risk. Let's see. Look like I kind of went a little too far. Hold just a minute. Seems like you see etiology. So I talked about that. And then something is up with my slides. Let me see something. 78. I don't know what happened, but my slides, they seem to be off for some reason. Uh, all right. All right. I think I may have it now. Patients, it seems really but this is the first all right, so take a look at the health issue. Then, of course, to find because of depression disorder. It could be something just as simple as toxicity, from medications that they're taking. Maybe their kidneys are not working very well, and the fact that they're on certain medications, and the liver may be even impacted, and so you have this toxic situation that occurs, affecting a patient's mental status, um, and what have you. So you have to really think about many things that would point to reasons why this person, fact that rather than to medical medication of the patient, should they take the decision that other people make those decisions. Very important discussion. As you can see, that we have already discussed, because we have shaking that I alluded to already. Let's see. I don't know why this thing is really doing some. The system is doing some really crazy stuff. Diagnosis. Right. Take a look at some of the nursing diagnosis. Excuse me. We have injury, balance, that's me. Okay, so And make sure you guys are reading what the nurse's responsibility is as it relates to these nursing diagnoses, because we test you on these things, because um, as I always tell you guys, you have to think like a nurse, right? And we can talk about a lot of the technical jargon as it relates to this condition. Um, we can talk about a lot of that. Uh, but um, your job is to really know what your responsibility is. For some reason, this slide seemed to have jumped around on me, and I don't know why. Let's see, lower risk. We talked about that. I know we did. Uh, Somehow it jumped around on me, which is really odd. So what I would do is talk about delirium. We talked about delirium. I told you that this is a very important to understand. Patients. Um, and so now, it is a mental disturbance. It is an emergency. Older adults as well as was alcoholism, risk. Um, is can also be as a, which can be issues other type nutrition deficiencies. So, that these issues are present or will likely be present at some point. Now, often the most effective nursing intervention is to have a family member present to assist with orientation and also reassurance, right? Because patients, they respond to their family members a lot better than they do to strangers. And so the way we do visiting hours now, way back in the day, you had to go at a certain time. But I guess research has shown, not I guess, but research has shown how effective having a known face, a familiar face, involved in the care of these patients. All right. All right. Now we are into Parkinson's disease. All right. As far as the pathophysiology of Parkinson's disease, so the substantia nigra is a group of cells that are located in the basal ganglia. All right, which is situated deeply inside the brain. Um, that sounds like a lot, but just understand that these cells that are located in this part of the brain. So just think about it's in a certain part of the brain, and something is going to happen, or something is happening with these cells. right? So, in other words, these cells, they are responsible for the production of dopamine, right? Dopamine is an inhibitory neurotransmitter. Dopamine also facilitates the transmission of impulses from one neuron in the brain to another, and what have you. Now, in Parkinson's disease, so basically with this neurotransmitter dopamine, although it has many different functions, but it certainly controls coordinating smooth controlled movement. So think about movement when you think about dopamine, and it does some other things too. But in this particular instance, we're more concerned about it contributing to this movement, or why this does become a movement disorder. All right. Now, loss of dopamine function results in impairment of semi-automatic movements, and so movement is going to be impaired, as I mentioned. Parkinson's disease is also sometimes called an extra pyramidal disorder because it affects the extra pyramidal tracts that are located in the spinal cord that controls motor neurons, right? So when you think about the extra pyramidal tracts in the spinal cord, um, this disease is going to affect this part of the spinal cord as well. And again, this is what controls our motor movement because it is what? Motor neurons, right? Not sensory, but motor. Now, acetylcholine is an excitatory neurotransmitter and is secreted normally in individuals with Parkinson's disease. The normal balance of acetylcholine and dopamine is interrupted, of course, in these patients. And this actually causes a relative excessive amount of acetylcholine. And because there's this increase in acetylcholine, it results in the symptoms that you see in these patients where they have these Parkinson's patients. They have the tremors, they have the muscle rigidity. The muscles are very rigid. They also have what is called akinesia, which is loss of motor muscle movement. And so all of these symptoms are what you will see, or what we do see in these Parkinson's patients. All right. And as I said to you, when dopamine is not present, then it results in, or it adversely affects coordinating the smooth, controlled movements. It is also involved in regulating motor activity, and a deficit in dopamine production is associated with motor symptoms like those seen in these Parkinson's patients. They're stiff. They move slow, which is what we call bradykinesia, not to be confused with bradycardia. Uh-oh, everyone. You know what? I don't think you guys heard me because I was on. Uh, I cannot believe I did that. All right. All right. So I'm gonna actually start off. I don't know where I stopped off because I didn't. I thought I pushed the button to turn it back on, and evidently I didn't. So you all were probably listening to silence. And I'm going to have to tell you all that at some point when I see you. Anyway, so I'm just going to go back to the pathophysiology just in case that's where it stopped. Anyway, so let me just read it from here. So there's the as far as Parkinson's disease, the pathophysiology, there is a destruction of substantia nigra. This is located deep within the brain. All right. There are cells within this area of the brain that actually produces dopamine. And so the cells begin to die. And of course, there is a reduction of dopamine production, a decrease in dopamine production. And of course, these patients, they don't have that smooth, coordinated movement as patients who um, normally have enough dopamine in the brain. But there's also there's a decrease in dopamine. Very important that you know this. But yet there's an excessive amount of acetylcholine. Remember, acetylcholine is a movement transmitter as well, neurotransmitter as well. And with that increased acetylcholine, it causes a lot of the movements that you see with these patients. All right. Um, essentially, you'll see the tremors and the muscle rigidity, the akinesia, a loss of muscle movement, when there is too much um, acetylcholine um, within the synapses of the brain. So next time, I'm not going to go on mute because if I forget to turn it on, then that can create the same problem. Well, I just really need to pay attention to what I'm doing. Anyway, um, um, sometimes to this as all right. Take a look at the symptoms. There's muscular rigidity. Rolling. Right now, I'll let you guys read the rest of the information that I provided. Take a look at this image here. Essentially, tells you or gives you an image rather of what these patients look like. They have the mask-like facial expression, which they'll probably test you on. The voice is soft. They have this drooling and dysphagia, so they have problems swallowing, which means that you know that nutrition is going to be an issue with these patients. They have the hand tremor at rest. They have constipation because remember, not only are they not really drinking much or able to eat foods, let's say high in fiber and what have you, but they they may be suffering from dehydration, which means that you're more likely to develop constipation as a result. They're not moving also as much. Movement also helps prevent constipation. And these patients are going to have some movement issues since it is a movement disorder. Frequent urination with these patients. And then also think about if this is a male who has Parkinson's, but they also have an enlarged prostate, and so even more frequent urination. There's flexion at the knees as well as the hips in order to shift gravity, the center of gravity forward. Helps them to keep their balance, in other words. And also they have that short shuffling steps or gait as well. This system is doing some really weird stuff. Anyway, I think that's what's kind of taking some of my concentration away, along with being a little on the sick side. But I'm not going to claim it anyway. So take a look at the symptoms of this autonomic nervous system disorder. These patients. Well, I'm sorry. Let me back up. So some of the symptoms, other symptoms that you'll see, because it is an autonomic nervous system dysfunction, this diaphoresis, constipation. There's also orthostatic hypotension, meaning when they rise from a lying, sitting, or standing position, their systolic pressure may drop at least about 20 points. There's drooling and dysphagia. They also develop seborrhea, as well as frequent urination. Some of the diagnostic tests that you will see. Diagnosed of the patients. You know, let's see. All right, take a look at the therapeutic. We tend to do is talked about. So that is help. Let's see. Actually, let me go through this. So again, there's no cure for this condition. Treatment is going to be aimed at and controlling the symptoms that you might see, but also maximizing the patient's function as much as possible. Medications used to control the symptoms listed. Take a look at table 4810. All right. Now, many patients with Parkinson's disease, they do experience fluctuations in motor function, the ability to move, in other words, related to medications. And this is referred to as the on-off phenomenon. And basically, patients may have a decreased response to levodopa, especially as the dose wears off. Now, as the disease progresses, patients may notice that the off periods become less predictable, right, and occurs more rapidly. Remember the off period is essentially when the medication is not working. The on period is when the medication is working. So they have more off periods. All right. Now, the patient may have a delayed or absent response to the next dose of levodopa, resulting in the patient being stuck in the off stage and also being significantly disabled for that period of time. All right. Remember that off period is when nothing is actually happening. So fluctuations in motor function can be accompanied by other symptoms. Those symptoms include a pain. The patients may experience pain. They may experience diaphoresis, anxiety attacks, hallucinations, or mood swings that increase the disability associated with each episode. All right. Now, the on-off phenomenon that I speak of, so in Parkinson's disease, it refers to the sudden and unpredictable changes in a patient's ability to move due to these fluctuations in the effectiveness of the medications that we use to treat these patients, such as levodopa. During the on phase, the medications work very well, and the patient can move more easily. And again, this is during the on period. However, during the off period, the medication's effect would then wear off. All right. And this would cause a noticeable decrease in the patient's ability to move. You'll see stiffness in these patients. You'll see difficulty. They have difficulty starting or initiating movement. And as the disease progresses, these off periods become more frequent. And then you don't know when they're coming on. Right. And this will make it very difficult for these patients to manage their symptoms. Now, patients taking maximum doses of medications for Parkinson's disease symptoms, they may benefit from what we refer to as a medication holiday. Now, think about that word, holiday, right? So, if they're doing a medication holiday, then you're not giving them medications for a certain period of time. So basically, during a medication holiday, the patients are taken off of all of the medications for a time, and then, of course, they are restarted at a lower dose. Hospitalization may be necessary during this time in order to maintain safety. Now, there's another medication here, the COMT, the catechol O methyl transferase inhibitor that is given to these patients as well. These medications they're used in Parkinson's disease in order to enhance the effect of levodopa. All right. It is the primary medication used to manage the symptoms that you see. Now, COMT is an enzyme that breaks down levodopa before it can be converted into dopamine in the brain. So when we give these medications, what we're trying to do is inhibit this particular enzyme. These COMT inhibitors, they prolong the action of the drug levodopa, which will allow more levodopa to reach the brain. And of course, if I can allow more levodopa to reach the brain, then more will be available in the brain's neurosynapses. All right. So the COMT drugs, inhibitors that we use, all we're trying to do is to prevent the breaking down of the levodopa. That's pure and simple of what we're trying to accomplish. Because again, patients with Parkinson's, they lack a sufficient amount of dopamine. All right. Now, by making a controlled controlled lesion in the area, or if there's a lesion in the area, or actually, when you think about I think it's called a pallidotomy. There's actually a controlled lesion that is made by a neurosurgeon. You're actually making this incision on purpose in the brain. And what this does is it aims to reduce the abnormal activity in the brain, and it also improves the motor symptoms that the patient experiences. Now, this procedure is typically considered when medications are not providing adequate relief, and the patient has severe symptoms that significantly affect their quality of life. And also, the last one here is deep brain stimulation. Sometimes neurosurgeons might perform this particular procedure in order to improve symptoms for these patients. Take a look at the nursing diagnosis: impaired physical mobility, which makes sense. Self-care deficits, which involves stressing, feeding, toileting, as well as bathing. Risk for injury, right? And also diagnosis for dementia, since these patients with Parkinson's, sometimes they do develop dementia. Make sure you read page 990 or start with page 991 and look at what the nursing responsibility is. Um, so the next disease process would be Huntington's disease. Now, Huntington's disease is a progressive, hereditary, also degenerative, it's not curable neurological disorder. It was first described by a physician by the name of George Huntington back in 1872. He was a general practitioner in New York. And many cases around the world can be traced to specific individuals. Right now, Huntington's disease, or we also call it Huntington's chorea, is inherited in an autosomal dominant manner, which means that each offspring of an affected, if one of the parents are affected, they have a 50% chance of inheriting this disorder. So I want you guys to make sure you understand autosomal dominant trait, because we could ask you a question about that. And remember, if one of the parents has this condition, the child has a 50% chance of acquiring it as well. There is a mutation in a specific gene that has been identified, but the cause of the mutation is not known, of course. There's a protein called RHES or REES, something like that, and which may be responsible for the activation of a mutant protein that causes destruction of the cells in the corpus striatum. This is a part of the brain, of course. Destruction also occurs in the caudate nucleus and other deep nuclei of the brain. So this, again, is a brain disorder. And in portions of the cerebral cortex. That's a lot, but just know that there's destruction of these different areas of the brain, especially the fact that they control movement. Don't get too tied up in all of the scientific jargon. Now, this degeneration results in progressive loss of normal movement and also intellect, not just movement, but intellect. And the rate of the disease progression varies from one person to another. So some people, they will reach the end point a whole lot quicker than others. The signs and symptoms, you might see dementia in these patients. Essentially, you will likely to witness personality changes, inappropriate behavior, paranoia, as well as violence. They also have these chloroform type movements, right? It almost looks like they're dancing, right? There's also dysphagia, depression, and then, of course, death, especially more towards the end. Depression and suicide are pretty common in the early stages of this disease, especially when they're able to perform, the self murder. Um, so anyway, so yeah, so as the patient still has the ability or the cognitive ability to carry out the act, they're likely to commit suicide because you're teaching these patients about this disorder and they know that at some point they won't be able to do it. And it might be harder for them to convince someone else to help them do it. So they'll carry out the act themselves. But these patients will become more dependent on caregivers. Aspiration resulting in respiratory failure is the primary cause of death. All right. Remember, they have the issues with dysphagia. Lifespan following diagnosis is about 10 to 30 years. And so, some of them, they may get to live at least 30 years following diagnosis. All right. Signs and symptoms of, well, this is just a continuation of the signs and symptoms. Diagnostic tests, family history. So we find out that there's a history in the family. MRI, CT scans might be performed, might be helpful in diagnosis, or at least, ruling out other health issues. Genetic testing is available for prenatal use. And of course, depending on what that says, families, mothers and fathers, they might decide to terminate the pregnancy as a result. There's also genetic testing as well as counseling. And of course, the counseling might lead to terminating the pregnancy. Uh, let's see. Some of the therapeutic interventions for these patients is antipsychotic medications. Also, antidepressants. As I mentioned, they do experience depression. Anti-choreic agents. Remember, these patients have these choreiform type of movements, like they're dancing, and these drugs might be able to control those involuntary movements and the behavioral outbursts that is seen in these patients. Um, and also stem cell transplants. This is, of course, experimental at the moment. Research on the benefits of transplanting stem cells into the brain of patients with this disorder is still ongoing. And so don't know how long that would take before it ever does make it to mainstream medicine. All right. Let's see. I think we should be getting pretty close. All right. Let's take a look at Alzheimer's disease, the pathophysiology. There's this progressive degenerative disease. There's also neurofibrillatory tangles. Remember, in a normal brain, these neurofibrillatory parts of the brain are in more orderly. They're situated more orderly in the brain, but in an Alzheimer's patients, they're more tangled. They also develop neurotic plaque that builds up. The brain is supposed to remove this protein that develops in the brain normally. That is, and what happens here is the brain is not able to remove it, and so the plaque builds up in these patients. Alzheimer's is the most common type of dementia. And again, it is a progressive loss of mental functioning that interferes with the patient's ability, as far as their memory, ability to think clearly and also learn, and also their ability to function. Um, in most cases, you will not know that a person actually has Alzheimer's until an autopsy is performed. All right. It increases the incidence rather of Alzheimer's. It doubles for every 5 years. A person lives beyond the age of 65, which is very unfortunate. Um, and there's many causes, of course. There's that they theorized, and they think that it can be related to a virus or bacterial infection. also possibly an autoimmune dysfunction. Now, there are markers associated as far as blood work associated with Alzheimer's disease and can be found on several chromosomes. Um, Chromosome 21 in particular has been associated with Alzheimer's, and it is also the location of genetic abnormalities responsible for patients with Down's syndrome. Now, patients older than 40 who have Down syndrome, they usually develop Alzheimer's disease. It's just a part of that particular condition. Now, the correlation between the two disorders is still being studied, and lifestyle factors that increase the risk of Alzheimer's disease. Think about conditions such as hypertension, hypercholesterol, lemia, or high or increased cholesterol in the blood, poorly controlled diabetes. And with all of these, blood flow is going to be adversely or negatively impacted um, to the brain, or that you're not getting enough blood flow to the brain. And so that's why I think they believe that these conditions might be contributing factors. All right. Now, the cause of this condition is unknown. It may be genetics, and of course, as I mentioned, Down syndrome patients after the age of 40 can they typically develop Alzheimer's. Now, as I said before, the exact cause of this condition is not known, but structural changes have been well documented. Um, there's an abnormality that exists within the protein of the cell membrane of a neuron. Now, as the axon terminals and the dendrite branches disintegrate, remember that nerve that I showed you guys? It had like a round part with these looks like sticks that are sticking out of a head, and then it had like a long axon that looks like a worm, and so that is what we call the axon and the dendrite. All right, and so when this happens, as I mentioned, as the axons terminals and dendrite rather branches disintegrate or destroyed, then they begin to collect this neurotic plaque, the plaque that I told you that the brain typically is able to remove. Now, inside the brain is a precise arrangement of filaments and tubules, all right, that are responsible for the cell integrity of the brain. Now, individuals with Alzheimer's disease, they develop these neurofibrillary tangles. Remember, I was saying that the filaments and the tubules are more arranged, more orderly, but in this disease, they become more tangled. Um, and so they lack the characteristic orderly arrangement, in other words. Now, instead of remaining a small area of abnormality, these neurotic plaques and the neurofibrillary tangles, they spread across many of the axons to other areas of the brain. And so it's just not situated in one area. In addition, these patients, they tend to have a deficiency in acetylcholine in the cerebral cortex. And so remember that acetylcholine is a neurotransmitter that is important for nervous system function. It helps patients to move. So there's a lack of acetylcholine, which as far as treatment is concerned, we need to increase the amount of acetylcholine by giving a cholinesterase inhibitor, right? With decreasing or minimizing the erase, part of the enzyme, so that more acetylcholine is present. Now, advancement of the neurofibrillary tangles that I spoke of, as well as the plaque, it affects the hippocampus part of the brain first, and this results in short-term memory dysfunction. All right, Now, as the tangles and the plaque spread to the temporal lobe, memory impairment is going to be even more severe. Let me change the color of this because it'll be hard for you guys to see. Yeah. All right. Yeah. So anyway, so as um, the tangles and the plaque spread across the temporal lobe, again, you'll see this memory impairment that becomes more severe. Now, at this point, the patient may seek assistance from a healthcare a system, and there may be personality changes. They may be incontinent, um, which are inevitable. The inevitable results of someone experiencing Alzheimer's. And so these symptoms are attributed to the spread of the plaque and the tangles to the frontal lobe of the brain as well. All right. Now, it is believed that the younger the patient at the time of onset, the faster these neurofibrillatory tangles and the neurotic plaque is going to spread. Younger patients tend to deteriorate faster, and they require complete care much more earlier than the elderly patients. And they have a much shorter lifespan as well. Now, one area of the brain left relatively untouched by Alzheimer's disease is the subcortical area of the brain. This structure is responsible for our subconscious urge to survive. All right. The need for basic requirements such as shelter, food and water, security, and reproduction are controlled by this subcortical area of the brain, along with emotional response to situations. So the patient with Alzheimer's disease may experience hunger, but no longer know how to meet their basic need. Because remember, there's a cognitive aspect of this disease as well. All right. So these patients, essentially, what we're saying is they might starve to death because they don't know how to do something like, cook eggs like they knew how to do a while ago. Some of the signs and symptoms of Alzheimer's disease, you have stage one. They are rather in stages. Um, I believe some sources may have as many as seven stages, maybe nine. I believe your book speaks of I think it's three stages that your book speaks of. What I would have you to do is to take a look at each stage. Just looking at this, there's increasing forgetfulness. There's a progressive memory loss, irritability, depression, aphasia. There's sleep disruption, hallucinations, as well as seizures, is what you'll see in these patients. Of course, that's in your stage two. As far as stage three, there's complete dependency, bowel bladder control, emotional control is lost, and there's an inability to recognize significant others, and then finally, death. All right. As far as diagnostic tests, we have to look at the patient's history and see if that is revealing of anything. Physical examination, an MRI and a PET scan might show that there is something that is going on. For example, with the PET scan and the SPECT scan, it can show some neuronal inactivity, or the neurons are not firing normally as they are supposed to. Now, the MRI can show those classic neurofibrillatory tangles and also the plaque as well. Um, there is a new blood test that can also at least predict the risk that are being developed as well. And so that would be really great because then you don't have to, you can be proactive, of course, and you don't have to wait until someone dies to do an autopsy. Some of the therapeutic interventions, we have the cholinesterase inhibitors, because remember, we want to have more acetylcholine available in this patient. Um, the NMDA antagonists rather, medications that we have already discussed. Antidepressants, antipsychotic, as well as anti-anxiety agents are given to these patients. Take a look at the nursing diagnoses that are appropriate for this disorder: risk of injury, imbalanced nutrition, pretty much the same for most of them, chronic confusion, and risk for caregiver role strain. Right. And I believe that is it. Yeah, because the rest of this would be the different exercises. So I'm going to go ahead and stop. You know, I thought I had my camera on, and for some reason it was off. So you may hear my voice and but not see my face, which is all right anyway. So I don't know what's going on today. It could be just because I'm just not feeling as well. So, but hopefully you'll hear the voice, and I'll double check this just to make sure. I may have to end up doing it again, but we'll see. Thank you, everyone. I can't believe that.